Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome back to The View on GU. It's day 2 here at GU ASCO, focused on bladder cancer. I'm Chris Wallis, here with my co-host Aly-Khan Lalani, and we're going to walk you through the latest and greatest.
Yeah, bladder cancer, I mean, what a day, especially in terms of the perfect multi-D kind of conversations we need to have. So we had, a lot of perioperative work, both in bladder and upper tract. And then, we'll try at the end have some potpourri of the advanced disease. But Chris, why don't we start with the highly anticipated Checkmate 274? This was adjuvant nivolumab in, resected urothelial cancer. Why don't you take us through that? Because we had the updated OS data.
Absolutely. So, we've seen data from Checkmate 274 for many years. Many of us have changed our practice based on the DFS data we've seen to date. And I think we've all been waiting for OS data. We saw simulated OS data in the past, and now we have real patient OS data. And I think it, thankfully, luckily, we'll walk through the details, but reinforces, I would say, our treatment patterns. It does not, I would say, change what we're doing. It tells us that what we've been doing is probably the right thing. And so as we walk through, this is now 3-year follow-up of this data. Technically speaking, this becomes a post hoc analysis as we're out far enough past pre-specified analytic points. But our DFS updates are all in keeping with prior reports. And so we have in the, patients who got previous neoadjuvant therapy, we see a hazard ratio of like 0.58, really doubling progression-free survival from 8.3 months up to 19.6. In the patients who couldn't get neoadjuvant chemotherapy, we see a fairly similar effect, hazard ratio of 0.69. But the data I think everyone's waiting for is that OS data. And so again, to reiterate, this is patients with resected muscle-invasive bladder cancer. If they received neoadjuvant therapy, they had to have residual muscle-invasive disease. If they did not receive neoadjuvant, they had to have adverse features greater than T3 or node-positive disease. And what we see here in the intention to treat population is a really strong hazard ratio of 0.7, so a 30% relative reduction in the risk of mortality for patients who received that adjuvant therapy. In terms of absolute benefits, we're seeing at 3 years a 10% absolute reduction in the risk of mortality. So from 54% in the observation control arm up to 64% survival at 3 years. And I think this is a really meaningful, clinically impactful difference in survival. And I think one of the discussants really highlighted well that this compares favorably to adjuvant therapy across pretty much all tumor sites. And as we think to apply it to our practices, it's important to look at that in the context of clinically important subgroups. And so I'd say the first one we should think about is that neoadjuvant therapy treatment stratification. And so in patients who have received prior neoadjuvant, we see a hazard ratio of 0.74, and those who hadn't, 0.67. In either case, we're seeing significant and I think clinically meaningful reductions in mortality. And so this tells us that, for the time being, when we have clinical factors to guide us, adjuvant nivolumab is the standard of care for patients who've had resected muscle-invasive disease. We obviously have questions around, analyses from IMvigor and how can we use CT and DNA to do this better? Can we select patients based on PD-L1 status? And so, what do you think in your sort of clinical experience? How should we be doing that?
No, and I think that's really important because in our cancer center, we're fortunate we have a muscle-invasive, bladder cancer clinic. And so just to refresh for those at McMaster University, where I'm affiliated, all patients with MIBC or really even upper tract, which we're going to get to, are referred to our urothelial cancer clinic. We call it bladder clinic, but essentially every patient meets a med-onc, a rad-onc, and a uro-onc to exactly have these conversations about eligibility for neoadjuvant chemotherapy. So I would say with the denominator we see, our chemotherapy rates are quite high, higher than reported by virtue of this clinic. And then we have the baton passing in patients to, get the surgery or radiation. Now, this is why I agree with you. Our uptake of nivolumab has been high. And listen, when you can say if you got prior neoadjuvant chemotherapy or without prior neoadjuvant chemotherapy, that added 10% survival at 3 years. I mean, this is tangible to tell patients with pre-aggressive disease and in centers that should be specialized to do surgery. So I think this reinforces what we're doing. And, certainly we know that by definition, as you say, this is culling in, really the highest risk when you have this type of approach. And, I think that's has been very important to have. And clearly we can show that these patients have been, I think, living longer.
Absolutely. And I think, we've always thought about ways we can intensify therapy. Obviously, we can add more before surgery. We can add more after surgery. Everyone was excited this past fall at ESMO to see the first report of the Niagara trial. And we see some really interesting and important updates from that study here at ASCO GU. Maybe you want to walk us through those data.
Yeah, Niagara, to have an update, really, this update is about the impact of PCR and having some impact on long-term outcomes. So very briefly, just to refresh, this is, again, a muscle-invasive bladder cancer population allowing a clinical T2 up to N1. And these patients were randomized, as we know, to gem-cis, allowing GFRs down to 40, so split dosing, off to surgery and no treatment thereafter, versus the interventional arm of getting durva plus gem-cis for 4 cycles. So that was important because people wondered if we should go up to 6. I think 4 is enough. You get the surgery, in this case, by definition, and then durvalumab Q4 weekly for 8 cycles. So we knew that. We knew we had overall survival benefit. We know we had OS benefit. And so this was kind of looking at what did this update look like. So metastasis-free survival really fit with the event-free survival hazard ratio of 0.67 at the 2-year time point. That was improved by 10%. And I think that was really, really important. Initially, they had not had complete calculation of all the pathologic assessments. And so there was an initial analysis, an updated analysis. Ultimately, what we saw is that path-CR was 27% in that chemo-only arm versus 37% in the arm that got some immune therapy. We should probably talk about that later based on what we even think a good TURBT does. What's really important is the event-free survival was shown by those who got path-CR and those who didn't have. So the non-path-CR, obviously those who got a path-CR in either arm do better. So we know that. But that was improved between both arms, about 7% in those who got a durva versus not, even in the path-CR. And then non-path-CR, that improvement in event-free survival was from 49% to 53%. So either way, people improved. I think the key thing was the overall survival. So again, path-CR patients are going to do well. Still improved if you got durva pre and post, from 91% to 95% for that overall survival at the 2-year landmark. And then patients who were found not to have path-CR, chemo alone 69%, up to 74% in OS, right? By getting so-called pre and post IO. Now, again, these were exploratory, interesting analysis, so it's not really powered to looking at hazard ratios and confidence intervals, so you just have to be careful about, but at least I think it very fits with what we know. Importantly, we then were reaffirmed that this approach does not stop people from getting a surgery, even when you deal with those who counted as an event because they didn't get a surgery. And really all the safety signal was kind of, really maintained with how we do. So I think this becomes now, those two together are very interesting to contextualize, but I would say, very interesting to see this. What do you think from a urologist? I mean, the path-CR here.
Yeah.
What do you think about that?
So I think we had a very eloquent discussant, and we had a very interesting, maybe heated discussion and Q&A portion of this session, in part because of that exact question, which is to say, what do we think about this path-CR? Is it good enough? Is the control arm here of gem-cis getting a 27% path-CR rate what we would expect, what we would hope for, and could we do better? And so obviously there's a huge discussion around alternative neoadjuvant approaches we could take, and a lot of back and forth around the role of dose-dense MVAC, data from Vesper, data from Coxon, and so for me as a surgeon, I would set my hands a little bit. I send, you make the diagnosis, you send to the medical oncologist and you say, like, do the best you can for this guy. Yeah. And as you're doing that, how do you see gem-cis as the backbone of these trials?
First of all, we need to do what you're doing, which is referring these patients. Okay. Whether you have our kind of boutique clinics or not, I think that's really important to have. So you're doing the right thing, obviously, right? I will tell you, like, personally, probably as an artifact of my training in the US, I got very comfortable giving dose back, every 2 weeks. Cycles for 4 cycles gets things done in 8 weeks around the COVID era. That was kind of nice. Um, I will say the comments made about Vesper. So this was a trial comparing Dostanzemvac to GemCis. Remember, that was 6 cycles of Dostanzemvac because that was trying to be 6 cycles every 2 weeks is 12 weeks, 4 cycles of every 3 week GemCis or, Gem Platinum really should be GemCis at 12 weeks. There's a difference right there in terms of how much cisplatin you got. So comments saying Vesper shows Dostanzemvac is better and therefore, I think we got to contextualize. Those patients got more cisplatin in general. As a medical oncologist, I think those who treat in this space know that whether we call it selection bias or just inherent good clinical care, the folks that I think I can give Dostanzemvac and get through are generally those who are younger and fitter. I think about the 40-something-year-old or 50-year-old who was a firefighter, who that's the risk factor for getting bladder cancer, and we were able to get through Dostanzemvac and had a CR. I think about the young lady who was in her 40s, and I was able to get through Dostanzemvac. I mean, those path CRs are real. That's their experience, but those are very well-selected patients. And then you're now saying, well, let's look at Niagara. This allowed a GFR down to 40. There was split dosing occurring. These are very different populations. So even though you're saying, okay, well, let me see the path CR from here, you got to think about what's the patient that is getting a split dose and why do we have that. So all that is to be said that I think these path CRs are individually reported trials, which is reasonable. I do think there's probably some variability in path CR in terms of how it's reporting. I think then we say, what's the denominator? Is that including a clinical CR or not? And then we look at all these trials done in different eras with a different amount of cisplatin exposure and some fitter patients getting a certain regimen, and some physicians aren't comfortable with that. So it's very, to me, there was considerable uncertainty and imprecision about, even at the back of the room assessing the benefits between saying Dostanzemvac and GemCis. So that would be my take. I do wonder about doing, and just not that it would settle the score, but if that's such a big deal to people, then what about Dostanzemvac in a Niagara type approach? And I'm hopeful and as of this recording, quite keen to see that become more formalized in the potential Niagara 2 type study. But I think the reality is, for the take home for our group, get that neoadjuvant approach, have these patients seen in centers, and where we can then employ Niagara, I think we might be able to start leveraging that. It is clearly safe. I think that's fair.
And I think, from the surgeon angle, I think one of the interesting takeaways here is that even when you get a path CR, so even in the path CR subset, the Durva arm outperformed the control arm. So we can't do proper contribution of component analysis here. We don't have enough data to tease out the neoadjuvant IO versus the adjuvant IO components here. But in context of the Checkmate 274 data we just saw, I think this brings back to us that regardless of what neoadjuvant regime our medical oncology colleagues have initiated pre-surgery, we need to be thinking in the post-surgery setting about getting these patients back into that med-onc clinic for discussions. Clearly, if they started on a Niagara type regime, this data would suggest that we can't just omit the adjuvant component. And I think it's clearly something we want to understand better as we think about components of the therapy. We've got at least 3 moving parts, right? Neoadjuvant chemo, neoadjuvant IO, adjuvant IO, and how we put them all together for the best care of any individual patient.
And I think those comments were fair that we don't have, there's uncertainty in terms of how we do cross-trial comparisons or understand the component parts. There's comments about whether we should be doing trials now that evaluate each of the component parts. And then as soon as we say, okay, that might be a good idea to do, or we do IO with Dostanzemvac prior, guess what's going to happen? Maybe a combination like EVP is going to be there. And Chris, maybe one day, if we see path CR rates, and I would want to see that for those of EGFR 30 and more and 60 and more, if we can get path CR rates of over 50, 55%, are your colleagues or are you happy to say, hey, I don't need to do as many cystectomies now, maybe we retain that bladder? But, the field's going to move very fast. So I do wonder, and analogies were made to other cancer types, have we really understood component parts before we race ahead? Obviously, I think patients like to keep their bladder, but is everyone suitable for that? And then there's comments made about ctDNA. So this is great. But if someone goes and clears everything well in bladder cancer, are we certain because they responded well that means we curtail treatment? Or are those the patients who responded well where we are certain the adjuvant therapy should be going on because all their cancer cells benefited? Or we say, well, you've cleared and now we can curtail. And I think that's where we really should have prospective data to start telling patients curtailing or not, at a population level. So it's super cool. I think what's also really cool is trying to understand better the other partner in this whole urinary tract is the upper tract disease, thinking
Absolutely.
so-called about those patients with upper tract urothelial cancer involving the renal pelvis or ureter. We saw some data around that, Chris. Why don't you take us through that?
Yeah, so I think it's important to level set here, right? This is uncommon. This is a hard disease space to study because this is uncommon. We're talking like less than 10% of all urothelial malignancies, maybe 5, depending on which study you're reading. And so this is a tough disease space to get expertise and get experience on. And I think beyond that, when we think of muscle invasive bladder cancer, it's very easy with a TUR to get a very reliable assessment. And so we saw interesting studies here, but the first takeaway I would highlight for everyone is that our ability to accurately characterize upper tract disease is relatively limited. And so one of the key takeaways before we actually dive into the hypothesis of this study is they showed high levels of discordance between their pre-surgical evaluation in terms of using cytology and using imaging results and their final surgical pathology. So we have a lot of discordance. We have both under-assessment of risk and we have over-assessment of risk, understaging and overstaging of this disease. And so we're really flying in a really difficult situation, I would say. And so as we think about how to do this, obviously my clinical experience, and I don't know what yours is that upper tract disease, stage for stage, seems to be even worse than lower tract disease in urothelial cancer. So these are the patients I really worry about. Patients with bad upper tract disease often do quite poorly. And so finding ways to optimize and intensify therapy is really key here. We know really the only level 1 data, phase 3 trials come from POUT. That's an adjuvant context. So these are fully resected patients who are getting adjuvant chemo. Now, clearly, when we've taken out a kidney, our cis eligibility becomes a bit questionable in some cases. And so there's a lot of gem carbo in that cohort, and we want to be able to do better. So the rationale for a neoadjuvant approach is really predicated on that better renal function, treating with systemic therapy while you have 2 renal units rather than 1.
Mm-hmm.
And then also the idea that you can really provide that neoadjuvant benefit of getting micrometastatic disease, potential primary tumor downstaging before surgery. So, in that basis, we've had a couple of previous efforts looking at neoadjuvant approaches in upper tract. Probably the most recent and best known coming out of MSK, John Coleman looked at neoadjuvant gem-cis, really showed some beneficial results. But this trial, which is published in JCO, coming out of the Jetta group, looked at a neoadjuvant approach using durva and gem-cis for those who are eligible, or durva and gem-carb for those who were not. This is, as I mentioned, a hard group to characterize. So they insisted that it was clinical T3 or less, clinical node positive or less, but then they had to have some high-risk feature. And here, it was a little bit difficult to characterize. So this was high-grade disease on cytology or on biopsy or an infiltrative lesion based on CT scan. And so again, that just highlights our difficulties characterizing this disease before we embark on systemic therapy. And so, in this context, it's a small study. We have somewhere between 15 and 30 patients in each of the arms stratified by renal function. And we see, I would say, not super promising results. Interesting, but not promising, I would say. So we got path complete response rates of like 13% if you got cis, 5% if you got carbo. When we think about the context of the MSK data, we had pathological complete response rates of 19% with gem-cis in that cohort. So the addition of durva here, like for me as a surgeon, I'm not entirely sure, although we're muddying the waters a bit with the gem-carbo arm. We know that this study is showing us that adding the durva doesn't impair your ability to do the nephro-U, so it doesn't get in the way of surgery. It's not clear to me that it adds a ton. But to better answer that question, these authors are moving up to a phase 3 trial. So they're going to compare neoadjuvant chemo to neoadjuvant chemo IO for these patients with upper tract disease. I think it's an incredible undertaking. It's a rare disease. And kudos to them. If they can accrue out that trial, I think it'll be a real important contribution for us. But this is not an easy space to study.
Yeah, I agree. And it even makes you wonder about folks that, could we leverage radiation in this area before? How can we give the immunotherapy to these patients? For folks, just the Checkmate 274 adjuvant trial did have upper tract. That's the minority. NIAGARA was largely looking at bladder cancer patients. So, there's some differences. And no, I think it's important to do. These patients need to be understood better. These upper tract patients can get some sort of alteration testing in their pathology based on, ministry reimbursement criteria around the world. So I think it's important. Why don't we take us home with a couple of more maybe potpourris here very quickly. I'll just quickly in the perioperative space, interesting data from China looking at neoadjuvant disitamab vedotin or DV plus perioperative toripalimab as a PD-1 inhibitor in patients with MIBC and HER2 expression. So, this was a kind of sandwich type approach with patients with CT2, N1 disease, planned for surgery, HER2 expression of +1, 2, or 3, getting DV 2 milligrams per kilogram plus toripalimab, Q2 weekly for 6 cycles, planned for surgery, and then the adjuvant component of the toripalimab, again, Q2 weekly for 20 cycles. And really, this was a 47 patient enrolled study. Most were IHC2 and, 32% in IHC3. And interestingly, the patients that actually got surgery were only 33. I wonder what you think about that when you see that as just just at that point. And I know we're going to move forward here, but what do you think about that drop off?
So we think if we compare it to our other trials that we've just been discussing, things like Niagara, this is a very high drop off rate. And so the context of Niagara and the way it's primarily designed, every one of these patients is an event. When we're thinking event-free survival, as Niagara defined it, every one of these patients who did not get to cystectomy is an event. And we need to think about why. So 11 of these patients declined surgery. Arguably, that could be a good outcome. Maybe they had a path CR or a clinical CR at least, and they didn't want to have surgical consolidation. That's reasonable. A couple of them met it out on their neoadjuvant phase. And then one had such bad IO-related toxicity that they couldn't move forward with surgery. So I think it's a high rate, but it's important to understand not just what the rate is, but why these patients are not moving forward with surgery.
Yeah. No, and I think that's really important. PCR rate of 63.6% in those evaluable patients is pretty cool. A 12-month EFS rate of 92%. I think, look, this is HER2-directed therapy. This makes sense. There are going to be large phase 3 trials evaluating this. The question as always is the denominator to actually get here to find these patients. It's got to be worth the squeeze. So I wouldn't overinterpret more than that, except to say, look, it was nice to see some equity around the world with data from China. I think it's important to show this kind of sandwich or Niagara approach that is really HER2 directed. In the last couple of minutes, I know as a uro-oncologist, you're still interested in metastatic disease and you're interested in seeing that EVP data. Maybe take us home on the updated analysis of EV and Pembro in first-line treatment.
Yeah, this is, I think arguably the most impactful data we've had in the last few years is the introduction of EVP as a first-line metastatic urothelial treatment regime. And we have an update here, really up to about 2.5 years of data. So we're adding an additional year beyond previous reports. To me, someone never prescribing this regime, interesting to see that 12% of the patients in the intervention arm are still actively on therapy at 2.5 years. Now, clearly no one in the chemo arm is, because you're just going to get your cycles and be done. But it's interesting to see that sustained benefit in 12%. Even with the longer follow-up, we see very, very consistent PFS and OS effect measures relative to the primary report. So for PFS, we're seeing hazard ratio 0.48, 12.5 months versus 6.3 months. For OS, we're seeing a consistent hazard ratio around 0.51, median OS exceeding 2.5 years. interestingly, both cis-eligible and cis-ineligible populations benefiting basically the same, 0.54 and 0.50 as our hazard ratios. And so, there's no real new safety signals here. And there's a real demonstration that the longer we're following these patients, we're seeing really preserved efficacy effect estimates. And I think that's important because most clinical trials, as they mature, the effect estimates sort of drift towards one. Yep. And here we're adding a year of data and seeing no real drift. And I think it speaks to the sort of durability of response and benefit we're seeing with this regime.
Yeah, and I would just say in terms of rollout, as we wrap up here in Canada, we've had access more recently and hoping to see public reimbursement. Many countries have had access. I would say, look, there's still a grade 3 treatment-related adverse event of over 57%. So, rollout here, these patients are likely to benefit. There's a little bit of cost of doing business, like the toxicity profile might even be needed to get that really significant response, that long-term benefit. So many questions, right? Rolling this out, I think folks are very comfortable giving pembrolizumab. The contribution of EV in terms of toxicity, taking pauses, dose reductions, are there treatment-free intervals on one or both components? I mean, this is where moving forward is going to be really helpful. You do have to phone a friend sometimes if you need some help with the skin, neurological or other toxicities. And there's ways to guide people because at the end of the day, we want to see when we look at real world data, which you and I might do in a year or two or more, and we look back and say, actually in the real world, the actual duration of treatment fits with trials, or if there's treatment-free intervals, there's still ongoing benefits. So lots to tease out as we get into the real world.
Absolutely. It's exciting to see how it rolls out in metastatic, and the opportunities are endless, I would say, as we've just been discussing all these perioperative trials. Clearly, that's where many of us are interested to see EV moving next.
Yeah, I totally agree and follow this space. We'll probably cover that again later this year. It's been great. We got day 3 of renal still to come. So we're going to wrap up here. And on behalf of my co-host, Chris Wallis, I'm Aly-Khan Lalani. We'll see you again for the final day at GU ASCO. Bye for now.